I'm Harriette Van Spall, Associate Professor of Medicine from McMaster University, and I'm absolutely delighted to have with me Dr. Javed Butler and Professor Faiez Zannad, who are here at ACC 2022 with me to discuss the results of the DIAMOND trial. Dr. Butler, you just moved positions, so tell us where you are and what your new position entails.
Yeah, no, great to be here. Thank you for the invitation. Yes, I did change my jobs recently. So I'm in Dallas, Texas now. And I took a position as president of the Baylor Scott and White Research Institute, but I still maintain my affiliation with University of Mississippi, where I'm professor of medicine.
I'm also delighted to have my friend, Professor Faiez Zannad here. Faiez, why don't you introduce yourself?
Yes, I am a cardiologist and a heart failure specialist at University of Lorraine, but the recent change in my career is that I have given up my clinical work because I'm retired. You know, in France, we retire early, and I'm still in a position of being emeritus professor of therapeutics and cardiology.
So you get an early retirement to focus on what you love and what we all know you for. Welcome, both of you. I'm going to start by asking Professor Zannad about the use of RAS inhibition in HFrEF. We have these core pillars of HFrEF therapy that are life-saving, but are often used suboptimally or withdrawn among patients with HFrEF because of the concern of hyperkalemia. Can you tell us a bit more about this, Faiez?
Yeah, well, you have hit the nail on the head because I have dedicated 20, 30 years of my life into generating evidence, and we have the best possible evidence for treatment of HFrEF. Very smart, effective medications which prolong life and life-saving, yet they are not used properly. And this has been consistently shown in so many registry, real-world data. And the main reasons is safety, or more so concern about safety. And the recurrent issues are hypotension, worsened renal failure, worsened renal function, and hyperkalemia. These are main limitation of initiation or up titration, and main reason of discontinuation of RAS inhibitors. And the bottom line is that many of these medications have this common feature of increasing potassium and potentially also deteriorating renal function. And therefore, we really need solutions. We have been educating lots of doctors that while they may need worry much, there are ways to prevent, to manage, but still, it hasn't really changed so much. No progress so far. So we are really in much need for solutions in order to enable and facilitate the optimal use of RAS inhibition and also heart failure medication in general.
Right, and across registries in the world, we find that MRAs are perhaps the most underutilized of the 4 classes that are recommended in guidelines across the world, often withdrawn due to hyperkalemia. And on that note, I'm going to ask Javed to tell us about the DIAMOND trial and the research question that it sought to answer. Javed?
Yeah, so, as Faiez mentioned, I mean, there is this irony here that the patients who are at the highest risk for worse outcomes from heart failure are patients with advancing age, advanced heart failure, or comorbid conditions like diabetes or chronic kidney disease. And these are the patients at highest risk for hyperkalemia and get the least amount of therapy. So that's another sort of issue to deal with. So, the way we designed the DIAMOND trial is that we looked at 2 groups of patients. One are those patients who are hyperkalemic right now on RAS inhibitor therapy and who had heart failure with reduced ejection fraction. And a second group of patients who had a history of hyperkalemia in the past, on the basis of which RAS inhibitor therapy was compromised, not necessarily completely stopped or discontinued, but maybe one of the 2 was stopped or the doses were lowered or something like that. So there were these 2 strata. And we enrolled these patients in the trial to optimize their RAS inhibitor therapy with the use of patiromer, which is a novel potassium binder, to see that this strategy will, in the long run, do 3 things. 1, can it better control potassium levels despite of optimal RAS inhibitor therapy in this high-risk group of patients? 2, can it prevent future recurrent hyperkalemia events? And 3, will optimization actually last? And if it does, will it improve clinical outcomes? So multi-pronged aims.
And tell us about the mechanism of action of patiromer.
Yeah, so patiromer is a sort of a novel potassium binder, and it exchanges sodium for calcium, mostly in the colon, and it is not absorbed. So in that sense, it is pretty well tolerated, and it is just excreted out. So your serum potassium absorption that you eat is not absorbed as much, and the potassium levels are much better controlled.
Right, and we often use resin binders to manage hyperkalemia in patients on MRA, but we don't know whether they actually facilitate the continued therapies of MRA or change clinical outcomes, and this is what the trial initially sought to answer. Tell us about your exclusion criteria.
So the exclusion criteria were pretty much what other trials have done. So we didn't want sort of hemodynamically unstable patients, patients with hypotension, for instance. We were trying to optimize RAS inhibitor therapy, including MRAs, and MRAs are contraindicated in patients with GFR less than 30. So we excluded patients with GFR less than 30 as well. And then all those sort of the usual exclusion criteria like recent MI or recent cardiac surgery and stuff like that.
Right, and you had this run-in phase that we would love for you to explain. What was the purpose of the run-in?
Yeah, so, I mean, as all three of us know, whenever you're doing a clinical trial, there are many different ways of doing the trial. So you have to kind of just come up with the best compromise of a protocol. So one question was, is it an up titration trial or a down titration trial? In other words, do we take patients and just go up on RAS inhibitor therapy, and then whoever develops hyperkalemia develops hyperkalemia? The problem with that approach was then you don't know how many people will actually require patiromer, right? Because some patients may just go up and maybe their hyperkalemia in the past was not related to RAS inhibitor therapy. So we did the reverse. So what we did was that we first optimized RAS inhibitor therapy in a run-in phase using patiromer, so that when patients were randomized, they had both a need for patiromer and they were already optimized. And it was a withdrawal trial design where one arm of the patients continued patiromer and optimization, and the other, the patiromer was withdrawn and replaced by placebo in a double-blind fashion to see what happens with RAS inhibitor therapy. Now, what's interesting is that although the run-in phase was just to facilitate the clinical trial design, there was actually some really good insights in the run-in phase that we got, because as Faiez mentioned, there are 3 reasons why RAS inhibitor therapy is not optimized: hyperkalemia, worsening renal function, and hypotension. And there was a sizable amount of folks who said that, the patients who develop hyperkalemia are older with advanced heart failure and more comorbidities, that even if you were to give a potassium binder, you will still not be able to optimize therapy because people will be dizzy with low blood pressure and, creatinine bumps and all that kind of stuff. But in the run-in phase, we were able to optimize in this particular group of patients therapy in 85% of the patients. So it seems like that if hyperkalemia is the reason for RASi compromise, if you have a potassium binders, in the vast majority of the patients, you will be able to optimize.
Sure. So tell us how many people were enrolled in the run-in phase and how many people were randomized?
So there were about 12. So that's a little bit of a tricky question. So somewhere around 1,100 some patients were enrolled in the run-in phase, but only about 1,038 completed the run-in phase. And the reason for that is that during the peak of COVID pandemic, we could not be certain whether patients can get their investigational drugs or come back for serum potassium testing. So there was a group of patients who were in the run-in phase who we just discontinued the run-in phase, and we never completed. And then also because of this whole COVID pandemic, the event rate, the enrollment rate, the shipment issues, and repeated blood test issues, As you know, the primary aims of the trial was changed from a morbidity mortality trial to much more focus on potassium levels, hyperkalemia, and RAS enablement. So when that decision was made to change the aims of the trial, there were another 90 or so patients that were in the run-in phase, and that was discontinued. So there were, I think, if I'm not misquoting the number, I think there were about 1038 patients that completed the run-in phase, and 878, or about 85% of those were optimized, and these 878 were then randomized to continuing patiromer versus withdrawal.
Sure. And for the clinicians among us in implementation efforts, what potassium level did you exclude from the intervention group? Is there a potassium level that was deemed too high to benefit from patiromer?
Yeah, so this is a second issue where this whole issue about compromise in the global trial becomes really important from the clinical trial protocol. So remember that although subsequently it turned out to be an 878 patient trial, originally it was planned as a multi-thousand patient outcomes trial all across the globe. So we wanted to make it much more pragmatic. So we actually did not have any higher or lower limit of potassium. Remember that we had a pathway to come into the trial with just history of hyperkalemia, not even hyperkalemic at the time of enrollment. And the majority of the patients, 60% of the patient came through that pathway, that our average potassium levels were about 4.7. So we did not have a higher or lower limit per se. If you meet the criteria currently over 5 or history of over 5, no matter what it is today, but RASI was compromised in that setting.
Okay. Tell us about your baseline characteristics and findings.
So the baseline characteristics were, pretty much the usual patient population, high prevalence of diabetes, patients in their 70s. What was interesting was that our GFR, and I don't know the results yet, we'll sort of look at it. There was a small group of patients that started with GFR more than 30, but at the end of the run-in phase, the GFR fell to less than 30. So we have a size, very small experience with less than 30 as well, and we'll write it up. But nevertheless, about 40% of the patient came into the trial with hyperkalemia at baseline, and 60% with history of hyperkalemia. So we had one primary endpoint and 5 hierarchical secondary endpoint, all pre-specified while the trial was ongoing before the database lock or any unblinding. So the primary endpoint was mean change in the serum potassium level between the two groups. And the mean difference across all the serum potassium level measurements in the study was 0.1, which was statistically significant, and the trial met its primary endpoint. Now, at the face value, you can say, well, 0.1 may meet its statistical significance, but what's the big deal? It's just 0.1. But I do want to highlight that first, these are patients who are already tolerant and optimized. So this is not going up, but this is withdrawal. We had 60% low risk population. But the biggest thing is that in clinical practice, potassium levels go up when RASI doses are high, and potassium levels go down when the RASI doses are low. Here, what we were able to show that the potassium levels were lower despite higher RASI therapy. So just need to put this in a clinical context. So that was the primary endpoint. Our first secondary endpoint was time to serum potassium greater than 5.5. So there was about a 38% relative risk reduction in favor of patiromer. Our second endpoint was time to MRA dose reduction. That was in favor, again, about 35% relative risk reduction. The third was first and recurrent hyperkalemic event. That was again in favor of patiromer, again, about 38% relative risk reduction. The fourth was a win ratio, because not all hyperkalemic events are the same. So this was a win ratio of mortality, morbidity, potassium greater than 6.5, 6 to 6.5, and 5 to 6. That win ratio was in favor of patiromer, 53%, 1.53 was the win ratio. And then the last one was a comprehensive RASI use. We had created a score 0 to 8, depending on not on any medication, 0 to 50% or greater than 50% of the dose for ASARB, ARNI, beta blocker, and MRA. And that was 25% in favor of patiromer use. So the bottom line is that the study met all its pre-specified endpoint, the primary endpoint, and 5 secondary hierarchical endpoints.
Right, so multiple endpoints, all with consistent findings. What were the adverse effects of patiromer?
So the adverse effects really was pretty well tolerated. So overall discontinuation rate because of adverse events and overall adverse events were matched between the two groups. At least in this particular trial, there was no mismatch, and hypomagnesemia, the GI tolerance was fairly comparable as well. The only difference was in the hypokalemia rate. There was a higher hypokalemia rate with patiromer in excess of about 4.3%. So it was 15% in the patiromer arm and 10.7% in the placebo arm.
Okay, Faiez, I want to ask you, so there's this issue of polypharmacy in general that many patients cite as reasons for which they want to go off therapies, particularly as they start feeling better. And we have had lots of evidence to support the use of steroidal MRAs in HFrEF. Where do you think the use of non-steroidal MRAs might lie, given the findings of finerenone in diabetic kidney disease and the relative rates of hyperkalemia in that trial compared to trials that have tested steroidal MRAs? What are your thoughts?
Yeah, well, we are really very excited about non-steroidal MRA because these are now being investigated in different areas, by the way, than steroidal, and therefore in diabetes kidney disease, it's very promising, and the Fidelio and Figaro trials are delivering results which are really exciting, that the progression of renal, but also cardiovascular disease can be slowed, and with very hard events being prevented, cardiac and renal, with exposure to non-steroidal mineral receptor antagonist. And therefore, this expanding the indication of this class of drug, of MRAs in general, we have yet to see the results of this class in heart failure. We have the Fine Arts trial, which is ongoing in heart failure with preserved ejection fraction. And you know that the steroidal MRA in heart failure with preserved ejection fraction have mixed results with the top cat. It depends on which way you stand. The results are promising, but the evidence is not fully established. So we are very much, eager to hear from the Fine Arts. Now, when it comes to potassium, well, certainly the reason of developing non-steroidal MRA in the CKD space is because it was designed as to be supposedly kidney friendly because of the tissue distribution of this medication, which is more balanced between the heart and the kidney, and therefore probably have better kidney tolerance and certainly kidney efficacy. Now, when it comes to potassium from the Figaro and Fidelio, the rate of hyperkalemia was lower than when I have seen with mineral receptor antagonists in other indications, but these are different indications. And we have seen in Pearl HF, which was led by Bert Pitt and myself, that indeed we can push up the dose of spironolactone up to 50 with a lower rate of hyperkalemia in patients exposed to finerenone. But until we have a head-to-head comparison in same kind of patient and same kind of indication, we will not know for certain whether there is a lower rate of hyperkalemia with finerenone as compared to spironolactone and eplerenone. It's quite possible, and intuitively and from other circumstantial evidence, this is the expectation. But we really would like to see a head-to-head comparison sooner than later. I know that it's going to be challenging to run this head-to-head comparison, but it would be very valuable for the clinicians.
But from hyperkalemia perspective, another way to look at it is that even if we take it as a face value that steroidal MRAs and non-steroidal MRAs have a differential risk of hyperkalemia, and that non-steroidals have a lower risk of hyperkalemia. Another way to look at it is that these drugs are expanding the indications for the use of MRA in the population. So the total use of MRA will increase to a point that even with a lower risk, the absolute number of people running into these problems may actually increase over time.
One of the major limitations of MRAs is the renal function. The evidence with patients below 45 of eGFR is very low, and actually, if any, the benefit may be lost below this. The risk to benefit ratio is not favorable, and therefore expansion to CKD and lower eGFR is certainly one of the major advantages of non-steroidal.
Sure. The other strategy I wanted to mention was the use of SGLT2 inhibitors, which we know are effective in diabetics with CVD and heart failure across the EF spectrum and patients with CKD. And we have observational evidence from clinical trials that SGLT2 inhibitors facilitate the use of MRAs and are associated with lower incidence of severe hyperkalemia. So that might be another strategy that can help maintain patients on MRA. What are your thoughts about a combined SGLT2 inhibitor MRA pill, a bi-pill, so to speak? Faiez?
Well, this is very smart, and some companies are pursuing this. And I know that AstraZeneca is developing a new MRA modulator, not necessarily antagonist, by the way. And the plan is indeed to combine it with finerenone. With their dapagliflozin. And they've run already the Miracle trial, and they are planning a phase 3 trial. So the combination is very, very smart, for the very reason that you mentioned, fewer hyperkalemia, and the very recent result we have seen of combination and the effect on albuminuria is kind of synergistic. So both drugs are effective on albuminuria, not necessarily the same kind of albuminuria, not necessarily the same in the same kind of patient, and therefore there is a very important value in combining both. So the future is going to be combination therapy, and you mentioned the polypharmacy issue. So this may also be one of the solutions really of this issue of polypharmacy. Not only synergistic effect, but also maybe adherence will be improved. So we are very much excited about this potential.
I'm excited too. There's just so much innovation and evidence building in the heart failure space. I hope that this translates to implementation through some of these patient-centered ways of combining therapies, delivering care, and bridging the gaps that preclude optimal use of heart failure therapies. I want to thank the two of you for joining me today in this discussion. I appreciate your time. I appreciate the generosity with which you share your knowledge, and I can't wait to see you both again.
Thank you.
Thank you.